Great, welcome everybody. Welcome to this, the first of EU-PFF, the European Pulmonary Fibrosis Federation's conversations, rare conversations on pulmonary fibrosis, or rather rare pulmonary fibrosis conversations. It's a great, absolute pleasure for us that the first of these is on autoimmune pulmonary alveolar proteinosis, from here on aPAP. And it's very important for us because we're a federation of 19 countries, 22 patient organizations from across Europe. We all started as IPF, idiopathic pulmonary fibrosis, as the focus of our work about 10 years ago. A few years ago, we changed that and broadened it to include all types of pulmonary fibrosis, including those linked to autoimmune diseases, the ones that are non-idiopathic, where there's a known cause, but they're very diverse. But what we haven't done so far is to really focus on the rarest of all diseases. And I'm very glad that we've decided to do that and to make aPAP the first of those, because as we know, aPAP can lead on to pulmonary fibrosis for some patients. My name, by the way, is Steve Jones. I'm a member of the board of directors of EU-PFF. I'm really pleased to say we've got a fabulous, I'll be moderating today, and I'm pleased to say we've got a really wonderful and excellent list of speakers. We're going to kick off the session today with Kelsea Arford, who is an aPAP patient, diagnosed in 2022, and she formed the PAP, the PAP Alliance in the USA, in Denver, in 2025. So Kelsea is a real mover in this field from the patient perspective. And one of the questions we want to ask ourselves today is, how do we emulate that in Europe? Do we become part of the same single group, or do we think of setting up a separate group? But I'll leave Kelsea to tell her story in a short while. And then we've got three of the world's greatest experts on aPAP. We've got Bruce Trapnell, Professor of Medicine and Paediatrics at the University of Cincinnati. Welcome, Bruce. We've got Dr. Cormac McCarthy, who is an Associate Professor of Medicine in University College Dublin. And we've got Dr. Maria Kokosi, who is a consultant in ILD at the Royal Brompton and Harefield hospitals in London. So a wonderful speaker list today. We're going to take each speaker, it's going to talk in turn for about 15 minutes. We're not going to have any questions in between. When we finish, we'll have a brief comfort break for 5 minutes, and then we'll come back and we'll have a panel discussion and a question and answer session when you'll all have an opportunity to raise your points. Just a few housekeeping points to start with. Could you move on, Alba, please? Great, thank you. We ask you to do things. When you want to speak, please use the electronic hand. Do you know where you find that? At the bottom of your screen in React, you'll be able to put your hand up, signal when you want to talk, and we'll the raise hand, and then we'll know that you want to talk, and you'll come in order then. But I'd also like you just to very briefly put the purpose of your question, very short, very brief. I want to ask a question about this. If you could put that into the chat, that would help me take the questions in the order which is most appropriate for the discussion. So two things: you want to ask a question, you put a very brief, I want to ask a question about this in the chat, and then you raise your hand electronically and we'll know you want to speak. Okay, and on to the next one, please, Albert. We have a special facility. I don't know how many people want to make use of it today, but we can have a new Zoom feature which allows translated subtitles. So if you click on the arrow in show captions, which is that's at the bottom. Captions, if you on my screen at the very end on the right, there's one called more. You click more, you get a program, a menu there, and captions is one of those. Go through captions, turn on the translation option, and choose the language that you want to speak in. Thanks very much. Alba, quick question: do we need to do that for English speakers as well?
No, for English speakers.
It's all in English, so only for people who don't want to listen in English to the session. But first, before we go any further, we'd like to know who's here today. And so I'd like to, first of all, there are two questions. The first one: are you a patient or a carer, a patient advocate, a doctor, or are you some other category, a pharmaceutical company or whatever? And could you please click it. People are doing it. Okay, that's great. Oh, very exciting. So we're mostly patient and carers, which is exactly what we hoped, which is fabulous. So 60% patient, 10% advocates, and well, apart from the speakers, I hope we have no doctors or other HCPs reckoned. Okay, that's fabulous. So we know the speakers now have a clear idea who the audience is. And Albert, could you go on and now put the second question up? So for the majority of you who are patients or carers, can you tell us where you live? Do you live in North America, in Europe, including the UK, or do you live somewhere else? 27% in North America, 67% in Europe and the UK, and 6% elsewhere. That's fantastic. Thank you very much. I think that gives us a very good background. I'm really pleased to see so many European participants in the meeting. I mean, you're a group we don't normally have contact with from EU-PFF, but we'd very much like to in the future. Great. So, and onwards to the next, please. Great. We now turn to Kelsea. Welcome, Kelsea. I've introduced you already, I think. Kelsea is the founder of the PAP Alliance, based out of Denver, Colorado, and she's going to give us her personal story of living with aPAP, a patient's experience. So over to you, Kelsea.
Hello, everyone. Thank you so much for joining us today. I'm so excited about this opportunity. So I thought I'd start off by giving you kind of the journey to my diagnosis and treatment for aPAP. So my journey started in 2021. I had gone to my primary care provider to actually get some medication for my stomach. I was having some stomach issues and was eventually diagnosed with gastritis. Not a big deal. But while there, I was getting the normal check-ins. You know, they take your blood pressure, height, weight, pulse ox. And my doctor said to me, how are you breathing? How's that going for you? And I said, I'm fine. Why should I be concerned? And she said, yeah, the reason I'm concerned is your blood oxygen levels at 70%. When I heard that, I kind of, what? Should I be concerned? What's going on? And she said, yes. So I immediately was sent to the emergency room with the assumption that it might be a pulmonary embolism. Got there and they did a CT scan, and sure enough, no pulmonary embolism. But I did.
Sorry, do you mind if I just interrupt quickly?
Yeah.
If you want to see Kelsea on full screen, you have to change it yourself. Go to view at the top and put speaker, and you'll get Kelsea. Over to you, Kelsea. Thank you.
Yeah, no, you're fine. So yeah, so they did get the results back from the CT scan, no pulmonary embolism, so that was a win, but it started a 9 months journey to find out what was wrong with me. The CT scan showed crazy paved pattern in my lungs. So that is actually a telltale sign of pulmonary alveolar proteinosis. But unfortunately, the doctors that I was visiting just could not connect the dots. So they started doing a lot of testing. I did blood tests, bronchoscopy. They suggested a lung biopsy as well. On my second bronchoscopy, they unfortunately punctured my lung, which then led to a 2-week stay in the hospital waiting for my lung to reinflate while still doing tests, all different tests that they could even imagine and think of. Finally, I was released from the hospital and they sent me home with a tank of oxygen, a lovely oxygen machine waiting for me at home, a handful of steroids and antibiotics. And I did that regimen for about 6 weeks, went back to my doctor and found out that I was actually worse. At that point, I decided to get a different doctor, second opinion, and I went to a different hospital, which then started the same routine. Blood tests, bronchoscopies, you name it. And initially, I was diagnosed with autoimmune pulmonary alveolar proteinosis, and they sent me to a pulmonologist that specialized in that particular disease. When meeting with him, unfortunately, he decided that it was too rare of a disease. He actually hadn't seen it before in his clinic, and he revoked that diagnosis and started over with more testing. So at that point, I went through more testing, and eventually I happened to join a webinar that was discussing pulmonary alveolar proteinosis. I thought, well, I was diagnosed, I might as well give it a try, see if I can find anything out. And sure enough, I met actually a fellow patient who lives in the same state as me, and we touched base, and he said, have you done the blood test to get, you know, confirmation of aPAP? And I said, what blood test? So that then was the golden goose. That was what I took. I went back to my pulmonologist and I said, I'd like to take this test. And sure enough, I was diagnosed. I had aPAP. So once we finally got the diagnosis, after 9 months of me being tethered to oxygen and no treatment other than the supplemental oxygen, I was signed up for a whole lung lavage, which is a pretty intrusive procedure. Unfortunately, it is kind of one of the only treatments that's recommended for us. It involves 2 days of anesthesia for 6 to 8 hours, depending on the severity of the disease. You also pretty much get your lungs power washed, is the best way to kind of describe it. It's like a spin cycle for your lungs. So they go in and they clean out the accumulation that is what is the cause of our disease. Is our bodies have stopped cleaning our lungs. So all of the gunk that we normal people get in their lungs, we can't shed it. It doesn't, our body doesn't go and clean it anymore. And so unfortunately, we're stuck with really low oxygen rates. That's the big one. Coughing, fatigue is the big part of it. And so that's kind of the only treatment is the whole lung lavage. But fortunately, I got that. I started feeling better. I was off supplemental oxygen for 5 weeks, which was a victory. And once that was done, we started another treatment. So typically, the kind of treatment is statin. The reason why they prescribe a statin is because the surfactant that collects in our lungs is lipid, and cholesterol is also a lipid. And so they believe that might help clear our lungs and reduce the surfactant. But also there is an off-label drug that we take that actually reproduces the stimulating factor that our cells no longer make or utilize. And we inhale that through a nebulizer. Typically it's a daily intake, and that kind of is what we can do in between lung lavages. So the bonus is that this medication we take does give us some time between the whole lung lavages, but unfortunately they're never off the table. So yeah, it was definitely a life-changing experience, which led me to create PAP Alliance, because I really wanted to get our patients and caregivers involved and offer them information about the disease, information about treatments, and hopefully a cure. And so that's where this all came from.
You're muted, Steve.
Yeah. Okay. Okay. Thanks very much, Kelsea. That's wonderful. How do you feel other patients? I mean, in your experience, is their experience similar to yours?
Yes. So a majority of us actually do have a really long road to get a diagnosis because it is such a rare disease. And a lot of doctors kind of just aren't quite sure if that could really be it. Fortunately, we have the blood test now, which really is a slam dunk, and that benefits all of us. It's also a very easy test. It's a blood test. So you don't have to get a bronchoscopy or a lung biopsy or anything of that nature. But yes, I think that a majority of us do struggle to get a diagnosis, and that's what takes so long for us to get treatment.
Yeah. And I mean, how do you feel you are now? Do you feel you're stable and managing it, or how do you feel?
So I am actually very lucky. I guess I would consider myself like a mild to moderate in the disease category. I don't have as much severity as some of my fellow patients have. In my case, I've only had 2 lung lavages over the last 4 years, which I feel like is a win. But there's several patients in their community that have had up to 50 a year. So you can only imagine how much time they take away from their normal lives for treatments. So yes, I've been able to keep my disease pretty well stable, but there are difficulties with other patients for sure.
And I guess for those people, it must be totally debilitating because it must take you, what, a couple of weeks to get over a procedure like that?
Yeah, for me, it usually takes about 10 days just to kind of feel somewhat normal after the procedure. And in my case, that took me over a month to fully come off supplemental oxygen. So now I'm really very lucky. I'm able to not be on supplemental oxygen 24/7, which is a huge win. And the treatment plan I'm currently on is keeping my disease kind of at rest. So I'm not needing to go in as often for lavages.
That's good news. Well, look, I look forward to you. There'll be questions for you, I'm sure, from the audience, Kelsey, later on.
Yeah.
And now we'd like to move over to invite Dr. Maria Kokosi from the Royal Brompton Hospital in London to talk about what is aPAP, epidemiology, and clinical presentation. So, Maria, welcome and over to you.
Thank you, Steve, very much. Thank you. A big thanks to the European Pulmonary Fibrosis Federation and the Action for Pulmonary Fibrosis for organizing the webinar, focusing on this rare condition and giving me the opportunity to talk. So I will focus on autoimmune alveolar proteinosis, try to explain what is happening in this condition, some data on the prevalence of the disease, the clinical presentation, and tests we use in the clinic, more to assess the disease severity. So I cannot move my slide. Oh, okay. So pulmonary alveolar proteinosis was described first in 1958 by Rosen, Kastelman, and Libov, and they described a series of 26 patients with a unique, for those days, lung disease. Since then, many more patients have been diagnosed, but it remains a very rare condition. The prevalence of the disease is less than 10 patients per million, and its rarity really makes it very difficult to develop expertise, to accumulate knowledge, to organize clinical trials, to offer the patients clear and accurate prognosis. And before I go into explaining what alveolar proteinosis is really, need to look at risk factors, very important. Factors that cause the actual disease, but contribute to its development. And smoking is one, very important, as well as other occupational exposures, patients who work in construction, for example, mining, etc. And let's start with the normal lung. What happens when we inhale? So when we inhale, air goes through the trachea, the windpipe, into the main bronchial tubes, the large bronchi, into the lungs. But those bronchial tubes, they split into thousands of very small tubes. This is what we call bronchial tree. And at the end of those tiny bronchial tubes, we have the air sacs or alveoli. This is how they look. It is just at the end of the bronchial tree. It is millions of them, and they are wrapped in blood vessels, as you see here. The red and blue blood vessels, small arteries and veins. This is how the air sacs look inside. And what is the role now of the alveoli? Is the gas exchange. So what happens when we inhale is that oxygen goes in. This is the alveolus, and it is transferred through the alveolar membrane into the circulation, into the blood vessels. These are the blood vessels around the alveoli. So oxygen is transferred through the red blood vessels into the circulation and other organs. And at the same time, carbon dioxide through the blue vessels is transferred from the circulation into the air and removed from the body when we exhale. That's in very basic words is what is happening in the lungs and what is the function of our lungs. So alveoli, very, very important in gas exchange. And how is the function and the structure of the alveoli preserved? So this is an alveolus again in a healthy one, and this is the blood vessel around it. So there is a layer here which is called surfactant, and it is very important. Its role is to maintain the structure because the alveoli are elastic. So surfactant maintains the structure, the shape, but also the function of the alveoli. Surfactant is produced by these cells, alveolar epithelial cells type 2, and then it is removed by, it can be by the alveolar epithelial cells as well, but also the alveolar macrophages, and let's focus on those cells. So produced by the green ones, removed by the brown ones, the alveolar macrophages. And one important factor in this function, the production and the removal, is this GM-CSF that you hear a lot with your diagnosis. So the GM-CSF will bind on the surface of the alveolar macrophages. These are receptors for the GM-CSF, and it then helps the removal of the surfactant. Surfactant consists mostly of lipids, as you heard, cholesterol and other lipids, and only 10% protein. What happens now in alveolar proteinosis? And this is the alveolus now in alveolar proteinosis. We have here again the alveolar epithelial cells type 2, the GM-CSF, but in autoimmune disease, the patients develop antibodies against GM-CSF. So they block the GM-CSF and it cannot bind on the receptors. This is an alveolar macrophage, but you see how different it is from the other one, because in this one we have accumulation now of lipids and cholesterol which cannot be cleared. We call those alveolar macrophages, they are called foamy macrophages. The result is that the alveolus now is full of surfactant, debris, cholesterol, and other lipids. And this is what happens in alveolar proteinosis and why the oxygen exchange then is reduced, is impaired. Sorry. And let's go to this scheme. Again, it is the exchange through the alveoli. This is normal alveolus and the blood vessel around it. This is what happens in alveolar proteinosis in relatively earlier stages. We have partial filling of the alveoli and impaired gas exchange. This is a complete filling of the alveoli. And of course, as the disease progresses from trivial, moderate to severe, symptoms change, shortness of breath, cough, chest pain, susceptibility to infections, because this material, the surfactant, is a very good media for the development of bacteria or other microorganisms. And of course, again, as the disease progresses, we have reduction in the lung volumes, oxygen saturation, exercise tolerance, etc. And I will come back to this slide again. I talked more and we focus today on the autoimmune alveolar proteinosis with antibodies against GM-CSF, but I will just briefly mention other forms of pulmonary alveolar proteinosis, the hereditary form, where we have mutations in the genes that encode the receptors for GM-CSF. So this is the alveolar macrophage. We have normal GM-CSF, but there is a problem with the receptors here. So the genes responsible for the receptors are dysfunctional. So either the receptors are not present or they don't function appropriately, so the binding does not happen. Another form is congenital alveolar proteinosis, where the problem is in the actual surfactant, actually the production of surfactant. Again, it is a genetic disease. There are genes responsible for this. And we have the secondary alveolar proteinosis. It is secondary to other diseases such as malignancies, hematological disorders, chronic infections, and the problem is in the actual alveolar macrophages. From the US registry, we know that the majority of the patients have the autoimmune form of the disease, and only small proportions have the hereditary, congenital, and secondary alveolar proteinosis. You know that better than me. Symptoms, how the patients present. Main symptoms are shortness of breath on exertion and cough. Cough is often productive of white, yellow sputum, which can be very, very sticky. Chest pains are frequent, recurrent chest infections, and the more severe the disease, the more frequent the infections. Fatigue can be an issue, and weight loss. Hemoptysis is not as frequent, but can be one of the symptoms. Clinical examination. So if somebody listens to your lungs, there are crackles on auscultation. So it is as if thin hair is rubbed. That's how it sounds. Not characteristic of alveolar proteinosis, but definitely an abnormal finding that should lead to further investigations. Chest X-ray. If this is an X-ray of a normal individual, this is definitely abnormal X-ray and of a patient with alveolar proteinosis. We have bilateral, both sides, symmetrical changes, opacities as we call them. Some are gray, some are denser, more white. Again, we cannot give a diagnosis of alveolar proteinosis on the chest X-ray, but definitely these findings should prompt referral for a CT scan. And this is the CT of a patient with alveolar proteinosis. We have diffuse, as we call it, ground glass, this hazy background with some lining. It is called septal thickening in between. Similar findings, some denser, whiter areas. And you heard from Kelsea the term crazy paving. So this is a CT very characteristic of the condition, with a combination of background, grayness and haziness with those lines on top. It looks like cobblestones. It is not PAP the only condition where we have this crazy paving. There are other conditions, can be infections, pulmonary edema, etc., blood in the lungs. But when we have this pattern, we ought to suspect alveolar proteinosis and organize further investigations. Another test that is used for diagnostic purposes is the bronchoalveolar lavage, bronchoscopy, the diagnostic. I'm not talking about the whole lung lavage. The appearance of the fluid. So what we do with the bronchoalveolar lavage, we install normal saline into the lung, we go as far as we can with this thin tube, the bronchoscope, and we install normal saline, and then we aspirate it. This is how it looks in patients with alveolar proteinosis. So this is full of lipids, surfactants, etc. It gives this very characteristic staining, pus staining, and we can also see under the microscope the foamy macrophages. This is how foamy macrophages look in reality. Macrophages full of cholesterol. And what other tests do we use in our everyday practice? Not so much for the diagnosis, but to assess disease severity, response to treatment, etc. I'm going back to this because it's very important. And we said as the disease progresses, we see decreased lung volumes, oxygen saturation, gas transfer, blood gases, and exercise tolerance. How do we measure all these in our clinical practice? 6-minute walk test. You walk up and down the corridor for 6 minutes, and we monitor the distance, the response from the heart and the lungs with the heart rate and oxygen saturation. And what happens in alveolar proteinosis is that while the patients can have normal oxygen saturation at rest, they can be at 94, 96%, when they walk, the oxygen will drop. And of course, we monitor the degree of breathlessness. Another very important test, the blood gas, not very pleasant, but can give important information. We look at the alveolar arterial gradient. And this is what alveolar arterial gradient is. Again, the lungs, the alveoli, and the blood vessel around it is the difference in oxygen between the lungs and the arteries. If it is normal, it means that the oxygen is moving from the alveoli into the bloodstream without any problems. In alveolar proteinosis, this gradient is elevated because there is a problem in the transfer of the oxygen. The gas transfer, and you must have been, all of you must have been in this cabin for the measurement of the gas transfer, again gives information on the gas exchange and the transfer of oxygen from the alveoli into the blood vessels. And finally, the lung volumes, probably it is the test that will be affected later in the disease. The gas transfer is more sensitive and more representative of what is happening. But if this is the spirometry, it is a test where it is a forced maneuver. And if you think of the lungs as a balloon, a very elastic balloon, you breathe in, the balloon increases. But what happens in alveolar proteinosis is that we have a restrictive pattern, we have restriction. So the balloon, the air cannot go to the end. And we can measure that with the volume of the lungs, and we can use it at baseline and then follow up in the long term. So I try to explain what happens in alveolar proteinosis and what tests we use to assess the disease severity. I will finish with one of my patients who I think is also present today, and I think this is representative of many patients. He presented age 23 with shortness of breath on exertion and cough for 18 months. He didn't have any really exposures. There was no past medical history. He smoked very, very occasionally. He was treated quite long for asthma with inhalers, and that's quite a frequent scenario. Until during his studies, he was in the lab, and he in a lung function lab, and he volunteered for spirometry, which was restrictive. And then he did a kind of 6-minute walk test. So he walked up and down and measured his oxygen, which dropped to low 80s. And that's how he persuaded his general practitioner to refer him to the local respiratory team, where he had a CT scan, and you see again the crazy paving. And that's unfortunately the journey of many of you until you reach a diagnosis, until you are referred to a expert center. So pulmonary alveolar proteinosis is rare and often missed disease. Many patients can be misdiagnosed with conditions like asthma, and of course this causes major delays in the diagnosis treatment, while in the meantime the disease progresses. It is very, very important that we raise awareness for this disease so we can have the best outcomes for our patients. Thank you.
Great. Thank you very much indeed, Maria. I think as a pulmonary fibrosis patient, IPF patient, I can understand an awful lot of what you talked about, because in many ways it's very similar, restricted pattern, the same kind of basic tests. Really very instructive. Thank you very much indeed. It's now my pleasure to invite Cormac McCarthy from the University College Dublin, who's going to talk about the diagnosis of aPAP and standard of care. So welcome, Cormac. Are you okay? Are you on a proper computer now? You're muted, actually. Yeah.
Okay.
Great.
I
Well,
have found a working computer. Sorry.
Okay, fine. That's great.
But I couldn't find how to unmute myself, so it's not that well working.
Yeah, I try to do it on a mobile sometimes myself, and it's very difficult.
Yeah. So yeah, sorry that took a few minutes, but yeah, so I'm going to speak a little bit, follow on from Maria, and there'll be a little bit of overlap, so I hope not to, cause too much overlap, but we're going to follow on from how we make a diagnosis of aPAP particularly. And Maria's given a broad overview of how pulmonary alveolar proteinosis is a syndrome of many different diseases, but primarily the vast majority are caused by autoimmune PAP. So these are just my disclosures. Okay, sorry. Okay. So and Maria's kind of explained this, where you've got this progressive accumulation of alveolar surfactant, the classic finding being these foamy lipid or cholesterol-laden macrophages, and you get restrictive lung impairment, hypoxemia, respiratory insufficiency, and in severe cases, this can cause respiratory failure, recurrent infections, and very occasionally death. Maria has very clearly shown the radiological appearance. And one thing that's really important to note is, and to reiterate what she said, is it's not always the crazy paving. It can present in a much more subtle way. It can present with very minimal changes, where you only have a very minor ground glass changes, as we call them on CT scan. Or it can present where it's misdiagnosed as pneumonia for a prolonged period, where you have these changes on your chest x-ray or your CT scan that look very much like pneumonia, and they get treated like that and it doesn't resolve. So it certainly is not always the classic crazy paving. So, and that's important because then we want to be able to prompt, when should you make a diagnosis? And again, that's just to reiterate, this is the classic finding, but one of the key things to remember is it's not only that as it presents. And then just to reiterate again, this is from some of the data from the PAP Foundation registry. The symptoms are very non-specific. They're breathlessness, fatigue, cough, sometimes sputum production. But again, these are very non-specific, very common findings in lots of patients with lung disorders or other breathing issues. So again, it's hard to say that this classic, symptoms go with a CT scan. So if you have an abnormal one, it's like, how do you think about it? And the differential for that kind of CT scan are really common things like pneumonia, heart failure, and then some other rare things as well, like pulmonary hemorrhage and then pneumonitis. And then Maria has shown some of this already, but again, there's primary pulmonary alveolar proteinosis, where it's again caused by abnormal signaling in GM-CSF, which affects macrophage function in the lung. Then secondary PAP, which can be any cause that reduces the function or the number of these macrophages, things like hematological malignancies, cancers, some immune deficiency syndromes, and then very rarely there's congenital. But again, and not to labor the point too much, but almost all of the cases that we see are primary. They're affecting GM-CSF signaling, and the vast majority, 90% plus of all cases, are autoimmune PAP, which is important to be able to then understand how do you make that diagnosis, because that accounts for the vast majority of this otherwise rare syndrome. So how do we make a diagnosis? Well, I wanted to kind of, focus this because in the last few years, we published this European Respiratory Society guideline last year to guide us on the diagnosis and management of PAP. And so I've grounded my talk in that, because we've taken considerable effort to approach the diagnosis in a methodical way and to really give this a clear guidance based off the evidence. So we're not going to spend this too long, but in the guideline, we put together a task force that included patients and included people living with PAP, as well as clinicians and scientists who've been looking at this. And we had a number of questions about diagnosis and management. And I'm just going to briefly touch on the diagnosis questions and then just one of the management questions before Professor Trapnell talks about some of the other elements. In the end, we came up with what's called a diagnostic algorithm, and that's helpful for rare conditions when we want to see how do we make this diagnosis and what path should we follow, or should any clinician follow. So if someone has never seen this condition before or they suspect it, this is to help guide those patients. So that would be helpful for someone who said, I've never seen this before, and how can I think about it? So if you suspect it based off the findings that Maria has shown, the compatible history, plus or minus the BAL findings, then you should go to an antibody test. And then beyond that, there's a number of other paths in terms of when should you do a biopsy, when should you do other blood tests, when should you do genetic tests. So these are all built into this guideline. And Maria showed this already. One of the questions we asked in the guideline was, should we do a BAL or bronchoscopy with an alveolar lavage in all patients, again, as a diagnostic procedure, not as this washout of the lungs? And we looked at the data for that. And here in red, we recommend that this should be part of the diagnostic workup. And it doesn't come as a diagnostic procedure. It doesn't prove the underlying cause. But it may support that someone has pulmonary alveolar proteinosis, and may also rule out other things like infection or pulmonary hemorrhage where you have bleeding into the lungs that can cause similar CT scans. So it's a useful rule out test, and it can help point you towards the correct diagnosis, but it doesn't necessarily prove the underlying cause. But one thing that's important, I think, and why we need to look at this, and when we made these guidelines, the patient representatives, they expressed a preference for a test that allowed for a quick diagnosis without the need for more aggressive interventions. So, if they could get away without having to do this procedure, that'd be advantageous, and certainly without having to do things like a biopsy, so quick tests. And these are just some of the justifications. We know that about 90% of the cases will yield that you have the abnormalities. You can exclude these other infections, and that the milky fluid appearance is really helpful. So the other question we asked is, should patients undergo lung biopsy? And this was alluded to in the very first talk, where our patient representative spoke about how, her physician was saying maybe we should do a lung biopsy or not. And a lot of patients that we see with this syndrome have underwent a lung biopsy, but we think you can really avoid it in a lot of it. And this recommendation was to not routinely perform lung biopsy as part of the diagnostic workup. So we don't, recommend this as a first-line test. And if it's to be considered, you have to think of the benefits and limitations of the least invasive procedure. And really, if someone thinks it's PAP and they're going to do a lung biopsy, they should talk to an expert center, because you should rule out several other things, and there's several other steps before you need a biopsy. And why do we make this recommendation? So even though there's a good yield, most of the time you would find some element of PAP. There's limited data, and we did a study a number of years ago in the US PAP registry where we looked at 56 patients who had undergone biopsy, and these were patients who had and you can see here about a third of them had a surgical biopsy. They ended up having a surgical procedure. Some got a biopsy at the time of bronchoscopy, and then about a quarter got both a surgical biopsy and a transbronchial biopsy. So a lot of people had undergone this. These patients all had autoimmune PAP, and interestingly, in this study, of the ones who we know had autoimmune PAP that we proved later by the other methods, about a quarter of these patients didn't even demonstrate any PAP findings on the biopsy, because of the way that if you can remember from the CT scan, you've got normal beside abnormal areas. You can miss the abnormal area with a biopsy. It's very patchy. So it's not a very helpful procedure. So this led to us recommending that this is not a first-line test, and we should really reserve it only in cases where we've excluded all other possible avenues. And you can see it here. This is going back to the algorithm. So we only ever do a biopsy when we get down to here. This is the bottom of it, where we've done these BAL, antibody testing, genetic testing potentially, or other signaling testing. And then you come down to this very much the histology. Can you biopsy it? And even then, we still don't know what has driven it or caused it. And that's important. And as Maria has shown, some of the biology of what causes it is really important, because then if we can understand the biology, we can get the correct diagnosis and get more specific targeted treatments. So that led us to this question of antibody testing. So when should patients that we suspect have PAP undergo this antibody testing? And we made a very strong recommendation that it should be done for all patients with suspected or confirmed PAP syndrome. So we should do this for all patients because, again, it's non-invasive. We have to measure the levels, the antibody titers or levels, not just if they are there or not. A positive or negative antibody is not sufficient. So some laboratories and some doctors will say we had a positive antibody or a negative antibody, but that is insufficient. You have to have a certain level and read above a certain level for it to be useful, because you can find positive antibodies in people who do not have PAP. And the data for this is a really, really good test. It's almost 100% sensitive and specific. That means it almost always is able to rule in and out the diagnosis of autoimmune PAP. And you can see that here. This is just a graph where these are patients with antibody levels. And this is on the left in these circles here. These are patients with autoimmune PAP. You can see they all have elevated levels above a certain level. And then those who are healthy individuals have very small or very hard to measure levels, but some of them do have presence of antibodies. And you can see here, again, there's a dichotomy. Those who have abnormal high levels have autoimmune PAP, and those with normal or low levels do not. So you have a clear cutoff that we can say these patients have high levels of antibodies, they have autoimmune PAP. And it can distinguish it from other types of PAP and other types of lung disease. And you can see here, this is over many, many years. This is data that we published and Professor Trapnell from his laboratory over many, many years, where these are hundreds of patients with autoimmune PAP, and you can see their levels are all much, much higher than other PAP causing diseases. That's including hereditary, secondary causes, other lung diseases, and healthy individuals at the time. So we looked at this in detail. We looked at lots of different studies. We looked at large cohorts, over 300 patients. We had 3 methodology papers, and we made a strong recommendation that this is important. This is really, really important, and these antibodies should be used in the diagnosis of any case of PAP to look for autoimmune PAP. And again, it's a simple blood test. It accounts for 90% of cases. It's highly specific and sensitive, and you can stop the need for biopsy. And it also can inform treatment decisions about whether you treat them with targeting those antibodies or replacing GM-CSF, and that will be talked about by Dr. Trapnell. So now we've talked about how we make this diagnosis. You base it off your clinical information, your radiological features that point you in the right direction. BAL is helpful, lung biopsy is less helpful, and then antibody testing is extremely helpful. And then just the other standard of care that I'm going to speak about is, it's been alluded to already, what is a whole lung lavage and when should we do it? So again, in our guidelines, in our task force, we decided we needed some hierarchy of treatments. And what I mean by that is, once someone is diagnosed with autoimmune PAP and they're assessed with an expert centre, do they need treatment or not, depending on the severity of the condition? And following that referral and assessment, we suggested that either they get a whole lung lavage or inhaled GM-CSF. These are both strong recommendations, and they had different indications as to which one. And so the standard of care for many, many years has been whole lung lavage. And inhaled GM-CSF, there's emerging therapy, there's emerging evidence, there's newer trials, and Dr. Trapnell is going to go into that in detail. But to talk about whole lung lavage, we have to ask the question, who should get a whole lung lavage and when should it be used versus not, and is it beneficial? Should we be recommending it as experts to say you should do this in your patients? So just to recap, what a whole lung lavage is essentially is a patient is intubated on a ventilator and one lung is ventilated where there's a cuff, and you ventilate one lung and you wash out the other lung at that time. And you infuse, bags of warmed saline, over a couple of liters at a time, and you let that come in by gravity into the lung, into this affected lung, the one that you're washing out. And then the lung is percussed, so it's manually, hit a little bit, trying to remove this material. And it's like removing butter from a sponge is the description, to get this kind of, lipid, thick fluid out of the lung, and then to drain it out into this other, bottle below the, by gravity. And you do this over many, many times. And you can see the fluid here. It starts off as this much dark, milky, but sometimes bloody fluid. And as you do this over many, many liters, it gets clearer over time, seen in this bottom image. And it takes sometimes 30 to 50 liters of fluid to wash out the lung. And this has been going on. It's a successful procedure and has been useful for, for the 50 years that it's been in existence. But there are issues with it. We know it improves lung volumes. We know it can improve their lung, their oxygen levels, and what's called your diffusion capacity. But the median duration, benefit is about 15 months. So some people get 15 months, but you've got a huge range. Some people require one lavage in their life and never again, and others require multiple lavages on a very frequent basis. So it's variable as to what the benefit is. So we looked at the summary of evidence. We looked at lots of different case series. We looked lots of different populations, and we looked at both adults and children. And we found this, and not to make this too complicated, but these are all the studies here. And you can see here, this is looking at, does it improve oxygen levels? And you can see to the right of the graph means it says whole lung lavage is better or worse, and it favors it here. It improves oxygen levels. It improves your diffusion capacity, which is your breathing test to check your exchange of oxygen capacity. And it also improves your FVC, and a little less so in that case than in your DLCO or your oxygen levels. And often we use DLCO, this diffusion capacity or oxygen levels, as the main outcome measures in this condition. So we recommended performing bilateral, both lungs, whole lung lavage in patients with autoimmune PAP who have evidence of abnormal gas exchange and either symptoms or functional impairment. And what we mean by that is, do you have low oxygen levels requiring extra oxygen? Is your diffusion capacity reduced? Or are you getting symptomatic in combination with those? And it was a strong recommendation. When I say low certainty of evidence, the reason for that is there's even no clinical trials in this. This is all retrospective, long-standing data that has been done by clinical practice. There hasn't been a randomized trial where someone gets chosen to do a lavage versus no treatment, or a lavage versus another treatment. But it comes back to this hierarchy of treatments. And one of the things then is we couldn't differentiate which of these two treatments, inhaled GM-CSF or whole lung lavage, should be done as the first line. And they differ on the presentation. But I'm going to have Dr. Trapnell is going to take on and follow on some of the GM-CSF. But really, we're talking about diagnosis. It's rare syndrome, not a specific disease. However, autoimmune PAP accounts for over 90% of cases. And we have a really helpful test. Biopsy is not usually helpful, but the antibodies are diagnostic. And this is a blood test, a simple blood test that can diagnose a lung disease. There's very few lung diseases anywhere that have a blood test that can actually diagnose it. Really, we don't have very many at all, so that's, and at the moment, but it has changed based off our recent guideline. Whole lung lavage has been the standard of care for many, many years. There are issues, and some of the issues are when to do the procedure, how long it should be done, and just getting a standardized approach, because different centers do it in different ways. But again, just to give a very brief overview, and Dr. Trapnell is going to talk a little bit more about the advances in new treatments. But thank you for your attention, and happy to take any questions. And apologies that the slides were so awkward, Steve.
The slides were very good. Thank you very much, Cormac. That was an excellent talk. I think it built very much on what Maria said before. And now we look forward very much to welcoming Dr. Bruce Trapnell, Professor of Medicine and Paediatrics at the University of Cincinnati. Bruce, I think, would it be right to call Bruce one of the rock stars of this area of research? I think probably the rock star, maybe. So over to you, Bruce.
I think it would be right to call him Bruce. Anyway, so thanks for the intro, and for the other speakers for setting up a discussion of treatment. And I think that Alba is going to set up the slides here. Hopefully that's true. I'm not sure how this is going to work. And she's going to tell me.
I just need 1 second. Sorry.
Okay. So while she's doing that, I'll just say that I think I have eliminated all overlap. So there will be a need to remember some of the things that you heard before about how to measure the severity of disease in relation to a treatment. Alba, are we just about ready, or you're working on it? She's working on it. Okay. There we go. This is right. Okay, so I'll when I come to each outcome measure, I'll just say a word about it as a reminder of how it works and how it's useful in measuring whether a treatment leads to an improvement or not, and how it does so. So, right, so this is about treatment, and let's see, how do I do the slides, Alba?
Just use your mouse. You should be able to, or your keyboard, and you should be able to skip forward. There you go.
Work? Okay, all right. So this disclosure, so I consult for a number of pharmaceutical companies. Work with the PAP Foundation, several other foundations, get grants from our government and from the hospital I work at. And also Savara has funded the trials that most of the work that I'll talk about here. And I work with them. And I will, my disclaimer is that I'll talk about off-label therapy with granulocyte macrophage colony stimulation factor. That's GM-CSF. Let's see if I can do the slides. It's working good. So what I'll cover is a brief, this is all related to therapy, a brief summary of 30 years of trials that have been done. And then I'll focus on 3 trials that relate to 2 formulations of recombinant human GM-CSF. And I won't say this again, so I'll say it now, that GM-CSF is a molecule that, it's a protein molecule that is made by a variety of cells in the body, and it's very important in the lung in terms of organizing a number of functions that relate to lung structure, function, host defense. So the 3 trials I'll talk about are PAGE. This was a trial, a national phase 3 trial in Japan. That was with sargramostim. That's otherwise known as leukine. You might know leukine. Impala and Impala 2 are global studies using an E. coli version of the recombinant human GM-CSF called molgramostim. So on to the details. This first slide is the summary of 3 decades of trials, and I won't go through these. I just want to point out that the very first patient to receive recombinant GM-CSF was in 1996, 2 years after the serendipitous discovery that mice with GM-CSF deficiency developed this disease. And that led to John Seymour in Melbourne, Australia, to treat a patient. And this patient happened to respond well. He then went on to do another study, and a series of studies, small studies, were done over the years. And then eventually several large placebo-controlled studies were done, and I'll focus on that just now. On the right side of the slide, you can see the number of patients that were in each of these studies. They got bigger over time, the studies. And the 2 measures of lung function that Maria initially talked about and Cormac also mentioned are AADO2. That's the alveolar arterial oxygen difference in concentration. So when there's a block in transfer of oxygen from the lungs to the blood, this value goes up because the level of oxygen in the blood goes not so high. And DLCO is a different method to measure how well gas gets out of the lung and into the blood. And you can see that by all the green yeses that most of these studies showed improvement in lung function, the primary lung function, gas transfer, in those studies. So that's the summary. The next is the study in Japan. This is the phase 3 randomized, blinded, placebo-controlled clinical trial of inhaled sargramostim that was done in Japan. And the study design is shown here. There were 2 groups. You either got placebo, as shown in gray, or sargramostim, again, otherwise known as leukine. And the way they gave that was 125 micrograms twice a day on 7 days, and then nothing on days 8 through 14 of 12 2-week cycles. So every other week you got daily drug. And that study showed a difference in the primary endpoint, which was AADO2. That's the alveolar arterial oxygen difference. And you can see the data. This is just aggregate data. You don't see the individual patient level data, but there was a statistically significant increase in gas transfer as measured by a decrease in the ADO2 in the patients that got leukine or sargramostim. The other measurement that they did that was clinically, or that was significant, that is to say that it was important, is that they showed a change in the chest CT in terms of lung density. You can actually measure the density of each little part of the lung, what's called a voxel. It's like a pixel on TV, only in 3 dimensions, so it's a voxel. And there was a difference in the density, and that correlates with, or it indicates with treatment, a reduction in the amount of surfactant in the lung. Those are the 2 significant findings of the PAGE study. And on the basis of that study, sargramostim was approved for therapy of aPAP in Japan. That's the only country where it's approved. The next trial I'm going to cover is the Impala trial. This was a phase 2-3 study, a randomized, blinded, placebo-controlled trial of inhaled molgramostim. And this is recombinant human GM-CSF made in E. coli. And this trial was Brompton versus placebo. And the study design had 3 groups. This is the first Impala study, 3 groups. You either got placebo, which is just no drug, or you got molgramostim. This is in the middle of the diagram there. You got molgramostim daily every other week, or the other group was you got molgramostim every day of every week. And then the measures, oh, sorry, that was the blinded period, and then there was an open label treatment extension period. And the measures for this involved evaluation of the blinded period for a demonstration of efficacy, and over the entire period for evaluating the safety. So the analysis is shown in the next couple of slides here. This is the 3 groups, and it shows how many patients were initially evaluated, how many were recruited and assigned and studied in the particular trial. And you can see the number of patients in the continuous molgramostim group, that's every day, the intermittent molgramostim group, that's daily every other week, and placebo. And then you can see the patients that received the treatment, the patients that ended up with valid data at the end of the study, and those that completed the open label study. And the point to make here is that everybody who completed or most of the patients that completed the blinded period also went on to continue in the open label period, and we'll come to that data in just a bit. So, right, so the primary analysis was a comparison of the continuous treatment group to the placebo group. And there's an ordered structure to how the analysis is done. You have to pre-specify what you think is going to happen and how you think it's going to happen and how you're going to measure how it happens. And so based on that, the first analysis or primary analysis was the comparison of these 2 groups. And so I'll show the data for that comparison. Here, the second analysis is the comparison of the intermittent group to placebo. So now I'm not going to talk about that because it wasn't significant. And let me get on to the data for the primary analysis during the blinded period. So this is the data for the primary endpoint. That's the main outcome measure for this trial. Okay, and it's change in AADO2. That's the alveolar arterial oxygen difference over time, and smaller values are better, showing improvement. And you can see the data over time for the blinded period, 24-week period. And at the end of that period, the people that had got the treatment had a lower value than the people who had gotten the placebo. And this was statistically significant. And so that was useful. Another measure, this was a secondary measure, not the primary measure. Another secondary measure in this study was the change in DLCO. This is a standardized lung function test that Maria talked about, where you measure the amount of carbon monoxide transferring from out of the lung into the blood. And so you can see that at the end of the blinded period of 24 weeks, there was a big difference in the DLCO. It was statistically significant, the difference. And so that was useful. There was also a change in a respiratory health quality of life measure. That's what's shown here. This is the St. George's Respiratory Questionnaire total score. This is the composite final major score for this questionnaire, the SGRQ total score. And it was designed for a different lung disease, but it happens to be useful in this one. Without going into the details, again, this measures respiratory health quality of life. And at the end of the blinded period of 24 weeks, you can see that there's a big difference between the treatment group and a placebo group. And this group was also significant, or this difference was also significant. Now, the next couple slides are about safety. And this was measured during the entire period of the study, the blinded period and the open label period. And it shows the measurement is the number of adverse events, that's negative things that happened during the study, either a new problem or a worsening of an old problem that happened during the blinded period. That's what's shown here. And there's the data shown are for the treatment group versus the placebo group. And you can look at this data in various ways. You can measure it by all the adverse events, and you can see that's pretty similar. Those adverse events that are probably or possibly related to the treatment that was given, and that's also similar, treatment and placebo. Adverse events that lead to discontinuation of the intervention, low and similar. And serious adverse events. For example, if somebody dies, that's as serious as it gets. And so those kinds of events, there weren't deaths, but those kinds of serious events were also similar. You can just see that that similarity indicates that there was no important difference between the rate of adverse events between the treatment group and the placebo group. This was for Impala, what I think of as Impala 1. It's really the Impala study. Now the Impala 2 trial, it was done, and the reason it was done was to gather more data in a phase 3 manner. It's a specific kind of a trial that is the one that you use to get a drug approved. And in this case, it had a different design for the purpose of the study, and we'll come to that in just a second. So this was also a randomized, blinded, placebo-controlled clinical trial of inhaled molgramostim versus placebo. And in this group, there were only two, or in this study, there were only two groups, treatment or placebo during the blinded period. And then there was also an open label treatment period, just like the first study. And you can see the various timings of all this. The treatment period that was the blinded period was now 48 weeks. And the open label treatment extension period is 96 weeks. I'm just going to talk about the blinded period treatment here now, but and that's again the data that happened over the course of 48 weeks. The primary outcome measure was measured at 24 weeks. Secondary outcome measures were evaluated at various times, and we'll come to that. Okay, so the primary endpoint was the change in DLCO at 24 weeks. And you can see here in this graph of the change in DLCO from baseline over the period of the double-blinded evaluation. You can see that at 24 weeks, the time of the primary endpoint, there was a highly statistically significant difference between the treatment group and the placebo group. And at the end of 48 weeks, a secondary endpoint in this study, there was also a continued difference that was highly statistically significant. So the gas exchange improved over the entire time of this blinded period in the treatment group. And you can see also that there was a small effect in the placebo group that plateaued out at about between 3 and 4% improvement. That's the clinical trial effect. Maybe patients stopped smoking, or they were just getting around more, whatever. But despite that trial effect, there was a clear-cut, statistically significant difference between the treatment group and the placebo group. This is, again, the primary endpoint at 24 weeks and the secondary endpoint at 48 weeks. The St. George's Respiratory Total Score was also evaluated here. And you can see after a brief period where there's the two groups are together, they separate and stay apart. And you can see the differences in the SGRQ total score between the two groups over the time. The SGRQ activity score is one of the components of this questionnaire. And so it forms a separate outcome measure. It relates to how well people can do activities. And you can see that there was a separation between the groups that was maintained over the treatment period of 48 weeks. And so that was also helpful in supporting the primary endpoint of this study. Another very important parameter in this Impala 2 study was the measurement of change in exercise capacity over time. No other study had demonstrated a significant change in exercise capacity with treatment before this particular study. And so that data is shown here. This is this shows the amount of exercise capacity measured by what's called peak METs. That relates to how much oxygen is being consumed. And so what you can see is that there's a difference between the groups in the peak METs over time that's maintained. It gets bigger. The difference gets bigger throughout the entire period. And so this was very helpful. Actually, the attribution at the bottom is not correct. It's now been published. It was published a few months ago in the New England Journal, along with the rest of the results for this trial, the primary results for the trial. Change in AADO2, this is another measure of gas transfer. This also was done as a secondary endpoint in the IMPALA-2 trial. Remember, it was the primary endpoint in IMPALA-1, but a secondary outcome in IMPALA-2. Still measures the same thing, the difference in alveolar and arterial oxygen concentration. And you can see that over the time, there's a continuous improvement in the in oxygen delivery by way of a continuously widening difference between the treatment group and the placebo group here. So this is also very supportive. As measured in the PAGE trial and also in IMPALA-1, there was a measure of surfactant burden based on a CT scan images. And I think most people with PAP know about this because this is part of their initial diagnosis most of the time. Anyway, so the parameter that was measured here in IMPALA-2 was the change in the ground glass opacification score, or GGO score. That's the fluffy white stuff, the ground glass opacification. Normally it's supposed to be dark, and when it's not, as shown in the bottom CT scan of a person that responded to treatment after 24 weeks, compared to the top scan where you see a lot of the fluffy white stuff, which is a surfactant, and that's measured as a ground glass opacification score. So you can see here that the difference between the groups for the change in the GGO score showed that there was a significant difference between the groups, with a better improvement in the milgramastim group. Right. A couple slides of safety for the IMPALA-2 study. This is adverse events measured during the blinded treatment period. Again, similar to placebo, and treatment is better, and lower values are better. And you can see that for all adverse events, there were very similar values for treatment and placebo. For serious adverse events, also similar and low. Those that were not related to the intervention, similar and low. Those that are possibly or probably related to treatment intervention, similar and low. And those that led to discontinuation of the intervention, either milgramastim or placebo, were also very low and similar again. So again, there was no major safety signal. If we really try to pick on data about safety, there were some differences which are not completely explained. So for example, this trial that was conducted during a global pandemic with COVID-19, there was a little difference in the SARS-CoV-2 infection, or COVID-19 infections. 18 people in the treatment group and only 8 in the placebo group, 22% versus 10. So it's a little bit higher. Again, this was across 16 countries and 40-some sites, and there were differences in how each country handled this kind of information. So it's not terribly surprising that there was differences here. And we'll get more information about this from the open label period, which we're not going to talk about today. So that'll corroborate or dismantle this concern. Other things like people getting nasopharyngitis, minor differences, diarrhea, again, minor differences, back pain, minor differences. Autoimmune PAP disease progression was noted as a disease-related adverse event. This was worse in the placebo group than it was in the treatment group, not surprisingly, and consistent with the treatment effect of the drug. So in conclusion, what's not shown, let me start with what's not shown here. I didn't say anything about the, well, I guess I did say something about the PAGE trial. Right, so compared to placebo, aPAP patients receiving sargramostim in the PAGE trial had greater improvement in oxygen transfer measured by the AADO2 and surfactant burden measured by CT scan densitometry. And in the IMPALA studies, Compared to placebo, aPAP patients receiving molgramostim, that's the recombinant human GM-CSF, had greater improvement in clinical, physiologic, and radiologic manifestations of aPAP when it was administered every day, but not when it was administered every other week daily. That was the Impala 1 study. And in the Impala 2 study, as well as the Impala 1 study, there was a reduction in the use of whole lung lavage as rescue therapy. The study wasn't designed to demonstrate that, but it was noted that there was a reduction. And there was no difference in the occurrence of severe or serious adverse events in either study. There's a need to do further studies if we want to know more about the optimal dose and other aspects of the treatment. But this is what I covered, and I think I'll stop there, except to say thank you to all the people that have made this possible, mostly the patients for participating in the studies, the care providers that referred patients and did the studies, and Savara for funding this work. And thank you for your attention. If you have any questions, my email address is there. I'm not very good about responding to email, but I will do my best. And if you have a question, you can send me an email. Thank you.
That's great. Thank you very much indeed, Bruce. I think your namesake would be proud of you. Okay, great. No, it's wonderful. Thank you. It's an excellent presentation. It's really good to have that information. I mean, I wish that we were in a similar position with pulmonary fibrosis caused by other means, where we can really, we haven't got such an optimistic picture as you have there. But great to hear it. We're going to take a short 5-minute break now. And I mean 5 minutes. We're going to start, well, I mean 7 minutes actually. We're going to start at 25 minutes past the hour with a panel discussion, and then we'll take Q&A. And we aim still to finish on the hour. If we want to go a little bit further, we'll see how it's going. If the discussion carries on, we maybe could do another 5 or 10 minutes. But okay, so quick 5-minute break now. And please come back on time, because we're going to start in 7 minutes' time. Thank you very much. Great. Welcome back, everybody. It's 25 past now. I can see a few faces. Bruce is here. Maria's here. Cormac, are you here as well?
Yeah.
Great. Fantastic. What we're going to do now is we're going to have a panel discussion. We've got about 35 minutes left. We're going to have a panel discussion to start with, and then we're going to open it up for general questions. If you've got a question that you'd like to ask, as I said, be ready to, when I tell you in about 10, 15 minutes, put your hands up electronically and send me a little chat, in the chat, just a title, a topic of what you want to ask a question about, so that I can make sure I get the people brought forward in a way that helps the discussion move forward. So I hope that's clear. Welcome back, panelists. Thank you all. Kelsea, you're here as well. Kelsea, yep. You're a really great series of presentations. We were just exchanging emails among those of us, or well, WhatsApp messages rather, among those of us who are organising the meeting, to say that was really among the best set of presentations we've ever had for one of these webinars. So thank you very much indeed for that. The one question that we agreed we would leave now until the panel discussion, we are primarily, and it's in the name, European Pulmonary Fibrosis Federation. We're interested in patients living with pulmonary fibrosis. And I'd just be really interested to know what proportion of people living with aPAP go on to get pulmonary fibrosis. And sadly, as we know all too well from, I myself had IPF and came very near to the end, people who, before a transplant, how many people go on to get pulmonary fibrosis and sadly, well, either luckily have a lung transplant or sadly die? Do we know those figures? Who would like to start?
Well, I can start because
Yeah, go ahead, Cormac.
On it recently, and the very quick answer is, Steve, we don't know the figures really well because there's a very limited longitudinal data over a long period of a large number of patients with PAP or aPAP to know how many develop fibrosis over time, and but it's probably a lot more common than we previously believed. We used to think there was not a lot of patients would develop fibrosis, but that's becoming much more apparent that over time patients certainly do. We've done a recent study from several centers looking at CT imaging over a period of time and having longitudinal follow-up. And in just under 80 patients where we're expanding that, where we had longitudinal follow-up, about 20 to 25% of patients had changes consistent with pulmonary fibrosis, like honeycombing and traction bronchiectasis on their CT scans at baseline, but about 40% by the follow-up CT scan had that. So, and that was over about a range of about, a median of about 38 months CT in between those. So certainly it's more common than we previously believed, but we don't know yet what the, what are the risk factors for that? Is it because they've got exposure to surfactant accumulating in the lung? What we noticed in the patients who got it, there was no obvious difference in terms of what treatments they had. So we don't think it was necessarily treatment related, but it's poorly understood, but it's certainly more prevalent than we believed. And
I mean, the risk factors that were mentioned earlier about exposures, cigarette smoking, industrial and other exposures, those are exactly the, some of the causes, probably we suspect, for some forms of pulmonary fibrosis anyway. So there's a commonality perhaps.
Certainly, and I think that's why you need a larger cohort of patients over a longer period of time for us to determine in PAP which patients get fibrosis. Is it those factors, or is it something inherent in the material that's accumulating in the lung causing a direct injury or something like that? We don't fully understand.
And have they maybe got the similar genetic predispositions that people with other forms of pulmonary fibrosis maybe have? So lots of really interesting questions.
Well, we're doing that as well. We're looking at even just the common carriers of MUC5B and things like that. There's a group in Europe who are doing that at the moment.
Thanks very much. Bruce, Maria, anything to add to that? Or?
I think that difficult to know who's going to get it, when they're going to get it, why they get it, and what to do about it. It is useful probably to think about aPAP as a disease with a component that is reversible, which is unlike most other lung diseases, and a component that's not reversible. The surfactant accumulation is reversible and progressive over time, and the pulmonary fibrosis is apparently not reversible as far as anybody knows now.
At the moment, yeah.
Whether it's preventable or possible to stop it or slow it is a point. And why does it happen? You know, maybe it's possible to figure out why it happens. One of the problems with trying to assess fibrosis, especially mild fibrosis, is that the surfactant that's present in the alveoli can obfuscate the mild fibrosis. So that makes it a challenge, you know, radiologically speaking. So maybe
I mean, in other forms of many types of pulmonary fibrosis, you do get a inflammatory followed by fibrotic, and yet sometimes you can remove or significantly reduce the inflammation without it necessarily progressing. So there's a kind of parallel there that I think we're used to. Maria, did you want to add anything more to that? Or?
Well, what I wanted to add is our experience, but of course it's a single center experience. The patients that developed fibrosis over time, there are not many, a small number, but they are patients who presented with severe disease and underwent multiple whole lung lavages. When I say multiple, patient had whole lung lavage every week for almost 6 months. So I cannot comment on early fibrosis because, as Professor Trapnell said, we don't know the surfactant masks any early changes, like whether those patients had an interstitial lung abnormalities, as we say in the fibrosing world. It's difficult to comment on that. But definitely our experience suggests that patients with severe disease, with multiple whole lung lavages, developed fibrosis over time. How this fibrosis is going to behave, will it remain stable or progress? I don't think we know.
Right. This sounds like a very fruitful area for future research, yeah? Certainly of much interest to us as well, and we'd like to participate with you on that if the chance comes. Is there when the three of you listen to each other speaking, and to Kelsea to start with, Kelsea, in fact, the four of you, what would you say you take away from this as the main messages? If you were to put it in a couple of bullet points for the patients listening today, what would you want their takeaway to be? Say maybe one each. What would you say, Cormac?
Well, the main takeaway, I think, from what I was asked to speak on today about diagnosis is, you know, uniquely in any lung disease, we have a blood test that is diagnostic of a lung disease, which is really rare. And especially, you'll know, Steve, from pulmonary fibrosis, to diagnose the underlying cause of fibrosis with a blood test is almost, you know, impossible. So we have a blood test that's really, really effective. And it's something that can avoid a lot of ambiguity and misdiagnosis. And I think, you know, from our, you know, own experience and from published, you know, data, a lot of patients undergo unnecessary or possibly unnecessary tests like biopsy, delayed diagnosis. And the test isn't just diagnostic, but guides therapy. And as Bruce nicely showed, the data for GM-CSF is really, really positive. So knowing you've got the correct diagnosis, and then you can get on correct.
That's fantastic. Yeah, it's great. Maria, do you have a one bullet you want to leave behind at one point?
So for me also, early diagnosis is very important. And as I said, the patient will which is the same with the patients with idiopathic pulmonary fibrosis. They will spend a couple of years being treated for irrelevant conditions until they receive a diagnosis. So for me, very, very important is to increase awareness for this disease. Increase awareness among physicians, but also strengthen the links between the patients, because it's a rare and very lonely disease. So it is important to develop connections among patients. I would be very, very keen to see a patient organization developing in the UK or in Europe. And I would like to encourage the patients to do that.
That's great. Thank you, Maria. And Bruce.
Well, I think those are a couple of, or actually multiple really good points. And I guess a point related to therapy is that I don't think we know, again, why people get fibrosis or what we can do about it. But there's clearly a fibrotic link to aPAP. Some patients get it. So my approach is, I think people need treatment. I don't think there is a group of patients that don't need treatment. I don't think we have evidence that there are patients that don't need treatment. And whole lung lavage is great if you're really, really sick. But if you're not so severe, maybe it's better to start with GM-CSF. And it is possible, and this is a speculation on my part, it is possible that if you take care of the lung problem, maybe you'll get rid of the fibrosis risk. So I would treat everybody, and I'd treat them right away. And lavage if you have to, but get on to the GM-CSF therapy, because that is the problem. It's missing. It's not, it's blocked. GM-CSF biology is blocked by the antibodies. And getting around that, at the way, based on what we know now, getting around that may be achieved by getting started with treatment early.
Yeah, and that make it clearer if there's something else going on in the background too. The picture will be clearer. Yeah, great.
Yeah.
Kelsea, you've probably heard it all before. I mean, in the position you are, not exactly, but you've been to many places where this is presented. What do you take away from this? I mean, you formed, so far as I know, or you formed the only patient organisation anywhere in the world for aPAP, which is a fantastic achievement. I think everybody's really grateful to you for that. Carry on. What do you think? Take it away.
I mean, for me personally, I was very alone when I was attempting to get a diagnosis. And so from the time 2021 to current, I'm really thrilled with how much more research and how much more information is out there for our patients. Because when I was initially diagnosed, I think there was 2 medical articles that really touched on aPAP. So that is a great benefit. And that is why I really triggered to do PAP Alliance, because I just want to build a community for all of us patients. They're so far and few between. So I think that it would be really great if we could get united and start spreading the word worldwide so that everybody can be involved.
Yeah, we need a global voice for aPAP patients worldwide. Yeah. I'd like to bring in my colleague, Liam Galvin now. Cormac certainly knows Liam well, from Ireland. Liam, can you join us, or?
Yeah, I can.
And then maybe you can ask your question.
Yeah.
We'd like to see your face. We'd like to see your face as well. Come on. There he is. Great.
Hi everyone. No, I listening to Kelsey's story, like there was 2 aspects to the question really that I had. Firstly, like, because she came there for another issue, but they did a routine health check and sort of flagged a concern. Does that mean generally that aPAP patients can continue with their sort of like undiagnosed just because the disease isn't impacting them for quite a long time? So is it a slow burn in terms of symptoms, or like in general? Because obviously with most progressive pulmonary fibrosis, it tends to be a very rapid onset of symptoms, gradually increasingly getting bad. And also the second part was that in many countries, like if I go see a physician, a primary care physician here in Ireland, they might look at your leg or your toe, whatever your problem is, or your stomach in Kelsey's case, and they wouldn't generally like listen to your lungs or test your pulse or do any of those treatments. So that's a big barrier to early red flags. So firstly, I just wanted to know, is that generally in America that if you go to see a GP on any reason, for any reason, they give you a general checkup, because that doesn't happen here in Ireland? And secondly, just what is the sort of general presentation of the disease? Does it really only come apparent after a good number of years?
Yeah, Kelsea.
So it is, I think the biggest issue is it's not necessarily a slow burn. It's more that the symptoms that we experience can be related to multiple other diseases. I mean, as all the doctors have already stated, some of us are treated for asthma, some of us are treated for, severe bronchitis, things of that nature. So in my case, I was not as symptomatic as some of the other patients in the community have had. And I mean, many of them in this room can attest to that. So for me, it was a random test that was taken. But yes, our primary care providers do, in my case, they do that health check at the beginning of every appointment, is just, you know, pulse ox, they listen to your lungs, you know, blood pressure, weight, height. So yeah, I mean, if that's something that's not going on in Europe, I strongly suggest you ask your doctors to do that.
It certainly is talking for the UK. I mean, even with a lung history as I have, you know, post-transplant and everything, it's not done automatically. You have to kind of almost request it, which seems kind of crazy.
So I feel like I need to make a couple of comments.
Yes.
The non-specific nature of the symptoms and the non-diagnostic nature of many of the tests that get done is a problem for sure. No question about it. But it would be a mistake to not think about the disease over the time course that it occurs. It is actually a very insidious onset, a slow onset. Most patients start with, you know, they might not be able to hike like they used to, and they initially think, oh, well, I'm out of shape because I'm older or I'm bigger or something. That's typically what happens in most people. And then it gets worse. And eventually, even while they're sitting in a chair, they can't breathe well. And then at some point in that time course, they come to the conclusion that, oh, I better go check this out, or somebody tells them that they better go check it out, like their husband or wife or something like that, or their kids. And then they get their initial evaluation, and they get into the system, and they get all these tests, and they don't know about the blood test, and they don't get the blood test at first. And so they get things like a lung biopsy and a chest tube and a couple weeks in a hospital, et cetera. So, but it's important to understand that this is a generally, in most patients, it is a very protracted problem that can manifest in different ways that allow somebody to come to clinic. So if you get an infection because you succumb to the infection risk, well, then you start coughing up blood, or you have a fever, but you don't otherwise have that generally for you know, the slow progression of disease, if that's all you have, the slow progression of disease. So there's various ways that it can present, but it's not like IPF where, you know, once you get the diagnosis, you're in super trouble in a couple of years. You know, it's not like that. It's a slow over many years most of the time. I'll stop there. I don't want to go on.
Right. No, I mean, it sounds familiar to the slow wait of being sorry, I've got my granddaughter knocking on the window outside. She's 2 years old. Sorry. She wants to know why she can't come in. Yeah, no, it's I think that sounds very much like IPF in a way. You know, you sometimes it's a cough that you go for before the breathlessness, but it's still, you go after a too long a period of time as a patient, and then the GP takes too long, is confused by the different signals they're getting for diseases which present the same way. So we both have a very long progression to, I mean, in the UK now, the average time to diagnosis with IPF is coming on about, it's about a year. I mean, it used to be much better than that, but it's absolutely appalling. So hang on.
And it's about you know, between 1 and 2 years for aPAP.
Yeah.
The time to diagnosis.
Great. Good. There's another question coming in the chat, I think. Yeah, you say it's yeah, sorry, it's Liam again asking the same question. Great. So are there any other sort of points you take from each other that was any other points that you'd like to raise that you think patients would be good hearing? I mean,
well, if nobody else has comments, I have one about severity. There's different ways to think about severity. One way to think about it is how often you'll need something like a whole lavage. And that's so you can measure the severity by how frequently you need whole lavage. And some people need lavage every few months, and some need it or receive it you know, less frequently. The median time has been reported at anywhere from 7 to 18 months between lavages. And so the first point is that it's progressive over time, the surfactant accumulation, and probably the fibrosis too, although we know not very much about that part, the latter part. And there's a great deal of variation among different patients in the rate at which they progress. So some people need treatment very frequently, and some people don't. And if you are doing a study and you don't observe people for long enough, you might think they're cured because they haven't got sick yet. And that, I think, is one of the misconceptions of treatment effects that gets reported in the medical literature.
I mean, is in the literature, do you find the sort of statistics you just talked about now, time between lavages, all that stuff, is it brought together in any one place? Have there been studies of the treatment profiles? If we were to come up with a, I don't know, a typical care pathway.
There's been some. One of the problems with reporting about PAP is that over the last 2 decades, our understanding of the syndrome, because it's really a collection of diseases, has progressed. And most of the publications in the literature talk about PAP as a thing, not a collection of things. And so that obfuscates the differences to some extent. And so we don't have as good as information as we'd like about the individual diseases, for example, like aPAP. So that going forward, it will be good to make sure that we're talking about a disease group like aPAP and then give specific information related to that. The first paper specifically about aPAP that I'm aware of is the paper that Cormac was the first author of that was in 2022 about the disease itself. Most other papers are about the syndrome.
So do we now have that rough estimate of, if you were to put it down to trying to get to specific diseases or causes of the syndrome in people with aPAP, can we break that? You did break, one of you gave a breakdown obviously into the hereditary and the other types, but within aPAP itself, are there types of the disease that we can distinguish?
That's an interesting question that I don't know the answer to. I'm not sure it's known. But there are, as Cormac was talking about, there's a somewhat poorly defined percentage of the population that has a graded fibrosis response. So it's possible that everybody's going to get it and it happens over time, or maybe not. That's not the case. But we need to study that so we understand the answers there. We really don't, and I don't want to spread a false idea that everybody's going to get it. Please don't take that message. That's not. It's just it's a question about who's going to get it and how are you going to figure it out.
Great. No, thank you. Kelsea, do you want to come in?
Yes, on my question.
Yeah, please.
Yeah. So yeah, I wanted to ask the doctors, what are your thoughts on spontaneous remission? I've heard, through the grapevine it has occurred, but it seems like there's far and few in between, and I just wanted more information in regards to that.
Well, I can reiterate what I just said a little bit, and then I'll be brief. They're like most autoimmune diseases, or many autoimmune diseases, there can be fluctuation in the disease, and I believe that there are cases where people have really had significant improvement. I think that's a thing that can happen. But I also think that it's possible to misunderstand a slow change as resolution if you don't follow the patients for long enough because they just haven't gotten worse yet. So that's a serious problem with reporting on the issue of spontaneous remission and improvement. You need to have a long enough duration of follow-up to really do a good job of that reporting.
Great.
Yeah,
you want to add anything to that? Come on,
yeah, no, I agree with Bruce. And one of the things we had this discussion before, Bruce, previously about even saying the word remission, we don't really know what that means. There's no definition of remission. And I think Bruce's point of there's some improvement, or you might have some resolution of CT findings or some improvement in lung function or symptoms, but we don't know what remission means. And some of that is probably due to some of the papers, one of the papers from Japan, which is 17 years ago, talked about a group that had spontaneous remission who were followed for a short period, not for a very long period. So whether that then ultimately resolved or resulted in some fibrotic change 15 years later, we don't know, because certainly there's, whether they came back with worsening, acute changes or kind of insidious reaccumulation. So actually, we don't really know if there's a thing called remission.
That's great.
So
Thank you both very much. Liam's come back with another question, which
the final
sorry, go
point
on,
that's
Bruce.
probably
Yeah.
important to make, I think, that at this point, based on that comment that Cormac just made, if people want to contribute to our understanding this problem, one way to do it is let your information in a de-identified way be part of a large collection of all the information we can manage to get over time. And so we're talking about a global registry. That's a way to understand the long-term consequences. It'll take time to understand it, but if we don't start with something like this, we won't get there.
Well, that sounds like a very good rallying call to think about. Maybe we can take that further outside the framework of the webinar tonight. We have another question from Liam. It's great that it appears that a possible treatment for aPAP appears likely. Does this mean that the potential risk of developing pulmonary fibrosis will be mitigated when you take the new drug? Or is it that hope that it's too early to say, or is it too early to say? And he says that to his mind, the lavages sound like they might cause severe damage similar to that's done by mechanical ventilation as well. As we know, many people coming out of COVID got a form of fibrosis which from the ventilation, which didn't become progressive, but it certainly damaged the lungs. Is it too early to say? Maria, what do you say?
Well, I think that as mentioned previously, the repeated whole lung lavage could be a factor contributing to the development of fibrosis, but not the only one. So yes, treating the disease early is definitely important, and treating with a drug, but it's difficult to tell whether we need to follow up the patients, and we need to understand the pulmonary fibrosis, the development of fibrosis, and the pathways behind it better.
Great. Thank you very much, Maria. Kelsea, what might be a final question for you is, what do we do from here? I mean, if we want to get a patient voice in the UK and Europe established, do you think we'd be better doing that as a part of a global organization, or would we be better keeping a North America and a European UK patient organization which cooperate together all the time but actually treat differently? Because I imagine the medical systems are different in different places. There are many factors that might make it easier. Time zones as well might help. But,
yeah, I've learned the time zones. That's definitely a different thing. For me, I personally would prefer a global outreach for it. I think that even though we do have different treatments based on different regions of the world, I think that this coming together and banding together as one will help us to have a better understanding of what is a better treatment across the board based on whatever country you live in. So my goal is definitely to get a global voice. Again, also because we are a small community, there's not a lot of us that have this. So the more that we have together, the stronger we will be in the long run.
Great. And that would certainly help for doing global campaigns, for example, for a registry and things like that.
Exactly.
Okay. Well, look, I think after this, we will send a brief questionnaire around to everybody who's participated, just particularly patients and carers. What we want the feedback on the event, but we'd also like to know their views on how they'd like to progress. I mean, we could set up a Europe chapter, if you like, of the bigger organization. We could hopefully we'll be able to meet face to face occasionally. We could do it jointly as one overall organization. The option I'll work with you, Kelsea, on drafting that so that we get the words right. Great. Well, look, it's been an absolutely wonderful afternoon. Are there any final comments? I have no more questions in the chat. Final comments from the speakers, if any? You've already given your one-word takeaway, but
yeah, I have one. It'd be a mistake to not mention that the existence of the PAP Foundation, which is a patient group that was started in about 2004 or 5, and is comprised of patients and care providers and others. And so that's another group that's dealing with this.
that's very good to know. I wasn't aware of that. Thank you very much indeed.
There's also one in Japan too. Sorry.
Sorry, it's also
there's another organization in Japan.
Okay.
Some patient organization.
So we need to look at making sure we are global in how we work. Yeah, Maria, do you have anything you'd like to add, or?
Not really. We'll just reiterate what I said previously. I'm hugely supportive of a patient group, global or not. But I would encourage, and I see a few of my patients have joined. I would encourage them to.
Great. Well, we'll be in touch with them by email after this event. And Cormac, anything?
Now, just to reiterate, I agree. You know, patient registries, directly reported registries, will be really important in such rare conditions from multiple nations. So I think having a patient group coordinate that so people can contribute their data, so we better understand the natural history and what treatments to give when. I think that's really, really key.
That's great. Thank you very much, Cormac. Kelsey, any final word, or did you say your final word just now?
Yeah, I'm just so appreciative for all of us banding together and being able to do this. So thank you very much to all the participants and patients and caregivers, as well as all the doctors, and of course EU-PFF. Thank you so much.
Great.
And I hope this can continue and we can get this, you know, becoming a regular thing.
Great. Well, thanks, Kelsey. It's been an absolute pleasure for us to host this meeting today. I think we've learned a lot more. I certainly have learned a lot more, and I think there's ways in which we can continue to work together going forward, which is great. Thanks everybody, especially thanks to our speakers, Maria, Cormac, Bruce, and Kelsey, for their amazing contributions this afternoon. We've recorded the presentations. It will be available on the EU-PFF website in time as well, with the permission of the authors, if they're happy with that. And there'll be other information as well on the syndrome, the aPAP syndrome. So thank you very much indeed. It's been very generous of you to give your time this Saturday weekend, and we look forward to hosting a similar event to this in another 6 or possibly 12 months' time. So thank you very much indeed, everybody. Thank you.
Thank you. Thank you.
Thank you.